Welcome to the Hospital Medicine Unplugged deep dive. Today we're tackling really one of the most challenging autoimmune disorders you might encounter in the hospital. Antiphospholipid syndrome, or APS. If you're dealing with a complex clot, maybe unexplained organ failure, or recurrent pregnancy loss, this deep dive is really designed to give you that precise diagnostic and management toolkit you need right now.
That's exactly right. Our goal here is to provide a bit of a shortcut, really, to understanding this pretty specialized area. We're focusing specifically on, how to diagnose it, how to spot those high-risk profiles that tell you who's likely to clot again.
Right.
And maybe most critically for anyone working inpatient, how to manage the really aggressive acute presentations, especially catastrophic APS.
Yep.
This is definitely one of those conditions where recognizing it early and acting decisively, often with, multiple therapies at once, is just non-negotiable.
Okay, so let's lay that groundwork first, just the fundamental definition. When we talk about antiphospholipid syndrome, what are the two core pieces that have to be there?
So simply put, APS is an acquired autoimmune condition that makes you prone to clotting, a prothrombotic disorder. It's fundamentally defined by having two things. First, the presence of specific antibodies, these antiphospholipid antibodies, or APO.
Okay.
And second, the clinical damage these antibodies actually cause. And that damage usually shows up either as thrombosis, could be arteries, veins, even small vessels, or as problems in pregnancy, like recurrent miscarriages or later losses.
So you need both, the lab finding and the clinical event.
Exactly. You absolutely must have both the lab evidence and the clinical event to make a definitive diagnosis. One without the other isn't APS by the standard definition.
Okay, so when we talk about that definitive diagnosis, we're really leaning on the established international consensus, right? Specifically the Sydney classification criteria from back in 2006.
That's the standard, yes.
And the key principle there, for you listening, seems clear. You need at least one clinical event, plus this persistent positivity for specific antibodies. And persistent is the operative word, isn't it? It needs confirmation twice, at least 12 weeks apart. Why is that 12-week gap so critical?
Cool. Yeah, that 12-week rule is absolutely essential. It really comes down to basic immunology.
Okay.
The reason for that minimum interval is to filter out antibodies that are just, transient, temporary spikes.
Wow.
You see, lots of things, especially acute infections, viral, bacterial, can cause a temporary rise in these antiphospholipid antibodies. But usually these are harmless and they just go away on their own pretty quickly.
Right, so you don't want to jump the gun.
Exactly. If we treated every single transient positive antibody test as full-blown APS, we'd be massively overdiagnosing people. And crucially, we'd be putting them on anticoagulants unnecessarily, which carry their own risks.
Makes sense.
So that persistence, documented 12 weeks apart, confirms that it's a durable pathological autoimmune process we're dealing with, not just a blip.
Okay, let's break down those clinical criteria then. You mentioned vascular thrombosis and pregnancy morbidity. What counts as a qualifying thrombotic event under the Sydney criteria?
So the criteria are quite specific here. It needs to be one or more episodes of thrombosis, could be arterial, venous, or even in the small vessels, but it must be confirmed objectively.
Meaning imaging or pathology.
Exactly. Confirmed by something like a CT angiogram, a venous Doppler ultrasound, or actual histopathology. And if it is pathology, the report needs to characterize the blockage as thrombosis. But there's a critical exclusion too.
Which is?
The pathology report must explicitly rule out significant inflammation within the vessel wall itself. If you see clear evidence of active destructive inflammation of the vessel wall, that points more towards a true vasculitis.
A different disease process entirely.
Right. Vasculitis has its own treatment pathway, often involving more intense immunosuppression. APS is primarily antibody-mediated clotting, not vessel wall destruction. That distinction is key.
Got it. That nuance in the path report is vital. Okay, now let's shift to the obstetric criteria. This often presents a totally different kind of challenge, often, frankly, a heartbreaking one for patients. What are the three specific ways pregnancy morbidity can meet the criteria?
Right. The obstetric side is tough. The first definition focuses on later pregnancy loss. It's defined as one or more unexplained fetal deaths occurring at or beyond the 10th week of gestation.
And unexplained is key there.
Absolutely. It usually involves a fetus that was developing normally, morphologically speaking. The loss points directly towards a major problem with the placenta, which is a classic site for the microthrombosis we see in APS.
Okay, so that's late loss. The second one involves premature birth, but it's linked specifically to placental issues.
Exactly. The second criterion is one or more premature births happening before the 34th week of gestation. But, crucially, the reason for the premature birth has to be linked to severe preeclampsia, eclampsia, or objectively demonstrated placental insufficiency.
So it's not just any preterm birth.
No. We need evidence that the placenta, that vital connection, failed because of clotting or related vascular problems. We're looking for proof of placental dysfunction driving that early delivery.
Understood. And the third definition. That covers the earlier, repeated losses.
That's right. This is often the most common way APS presents in early pregnancy care. 3 or more unexplained consecutive spontaneous abortions, all occurring before the 10th week of gestation.
But again, unexplained means ruling other things out first.
Yes, and the Sydney criteria are very strict on this. This diagnosis can only be made after a thorough workup has meticulously excluded all other known causes, things like maternal anatomical issues, hormonal problems, or parental chromosome abnormalities.
Oh, you have to do that legwork first.
You have to. That exclusion process is what helps isolate the autoimmune factor, the APS, as the likely culprit behind those recurrent early losses.
That structure really helps guide the workup.
Yeah.
Okay, turning to the lab side now, the antibodies themselves. The Sydney criteria are specific about which ones count, and they require a certain level, right? Medium or a high titer.
Yes, they require the persistent presence, again 12 weeks apart, of at least one of 3 specific antibodies, and the level matters. The first one, and you could argue it's functionally the most important, is the lupus anticoagulant, or LA.
And that one's different because it's a functional test.
Exactly. It's unique. It's not measuring an amount, it's measuring an effect. We detect it using specialized coagulation tests like the dilute Russell Viper venom time, the DRVVT.
Right.
It's this paradoxical antibody. It actually inhibits clotting factors in the test tube, making the clotting time longer.
Which sounds like it prevents clots.
Right. But in the patient, it does the opposite. It causes significant, often catastrophic clotting. It's a functional hallmark of the disease.
Okay, so that's the LA, the functional test.
Yeah.
Then we have the 2 that are measured by ELISA, the quantitative ones.
Correct. The second is anticardiolipin antibodies, or ACL. We look for the IgG and/or IgM isotypes.
Mm-hmm.
And crucially, for classification purposes, these must be present at medium or high titer.
What does medium or high mean practically?
It usually means a level greater than 40 GPL or MPL units, or statistically above the 99th percentile for the lab's reference population. That titer isn't just academic, it's a kind of surrogate marker for how pathogenic the antibody likely is. Low positive levels are actually quite common in the general population and usually don't mean much clinically.
So the level really matters for ACL. And the third antibody.
The third piece is the anti-FET2 glycoprotein I antibody, often written as a FET2 GPI. Again, we're interested in the IgG and/or IgM isotypes. And similar to ACL, the titer needs to be above the 99th percentile for classification.
So ACL and anti-beta 2 GPI are related but distinct.
Yes, they're closely related, both target complexes involving phospholipids and proteins, but they are independent markers. You can be positive for one and not the other. And remember, that 12-week retesting rule applies to all 3 of these, LA, ACL, and A2 GPI, to confirm persistence.
Okay, so if a patient meets these criteria, the clinical event plus the persistent antibody, we then need to think about risk stratification. And this feels like maybe the single biggest takeaway for predicting what might happen next. We have to talk about the triple threat.
Absolutely. This is the highest risk profile we can identify in APS. If a patient is persistently positive for all 3 of those key antibodies, lupus anticoagulant, anticardiolipin, and anti-2 glycoprotein, the 5.
All 3 together.
All 3 together, persistently. That combination confers the highest possible risk for having another thrombotic event in the future. These are the patients who are almost guaranteed to clot again if they aren't treated effectively and consistently.
So seeing triple positive on a report should immediately raise alarm bells for long-term management.
Major alarm bells. When you encounter a triple positive patient, your strategy for secondary prevention, preventing the next clot, needs to be the most robust, the most aggressive one possible. Usually that means lifelong anticoagulation with warfarin, monitored very carefully.
It really drives home that it's not just if they have antibodies, but which ones and how many. We should also quickly mention the classification distinction. APS can be primary, meaning it occurs on its own.
Right, in isolation.
Or it can be secondary, where it's linked to another underlying autoimmune disease.
Correct. And by far, the most common autoimmune disease associated with secondary APS is systemic lupus erythematosus, or SLE.
Lupus.
Yep. Having both SLE and APS diagnosed significantly ramps up the complexity of management. You're not just fighting the clotting tendency from APS, you're also dealing with the systemic inflammation from lupus, which itself can fuel the clotting process. It's a tough combination.
Okay. Understanding the diagnosis is critical. Definitely.
Yeah.
But getting a handle on why APS actually causes clots helps us think about treatments that might go beyond just thinning the blood, right? Let's dive into the pathophysiology a bit. What's the core mechanism driving this? It starts with that protein, baby glycoprotein I.
Yeah, the mechanism is actually quite elegant in a destructive sort of way.
Yeah.
It really centers on this interaction between the patient's antiphospholipid antibodies, the APL, and this normal host protein, O2-glycoprotein I, or B2GPI.
Which normally just circulates harmlessly.
Exactly. B2GPI usually just floats around doing its thing, not causing any problems. But when these pathogenic APL antibodies bind to it, they fundamentally change its structure, its three-dimensional shape.
Okay, so the antibody binding forces a conformation change in the protein. What does that altered shape actually do?
Well, that change exposes what scientists call cryptic epitopes, basically hidden binding sites on the big 2-GPI molecule that weren't accessible before. This newly structured, now pathogenic complex, the antibody bound to the altered B2GPI, becomes really sticky.
Sticky to what?
It aggressively binds to cell surfaces, particularly the endothelial cells that line the inside of our blood vessels. It also binds to platelets and immune cells like monocytes. And this binding is the trigger. It kicks off this massive, localized inflammatory storm right there on the vessel wall. We often call it a thromboinflammatory disorder.
Thromboinflammatory. So it sounds like the clot isn't just a simple plumbing problem like a failure of normal anticoagulants. It's driven by inflammation.
That's a key insight, exactly. This pathogenic complex activates those key cells, the endothelium, the platelets, the monocytes. And when these cells get activated, they massively ramp up the production and release of something called tissue factor.
Tissue factor, the main trigger for clotting.
It's the primary molecular spark plug for the extrinsic coagulation cascade. It essentially flips a switch, turning the normally smooth anticoagulant lining of the blood vessel into a rough pro-clotting surface. Inflammation drives the clotting.
And we should probably mention the role of complement here too. I know it often gets overlooked in sort of standard APS, but it seems really crucial in the more severe acute situations.
Oh, absolutely. Complement activation is a critical amplifier in this whole process. It's part of our innate immune system, right? Normally fights infection. But when it gets activated by these antibody protein complexes on the cell surface, it adds fuel to the fire.
How so?
It directly causes more cell damage, ramps up the inflammation even further, and dramatically promotes the formation of tiny clots in the small vessels, the microvascular thrombosis that we see in the most devastating forms of APS, like CAPS. If you really want to shut down the most aggressive disease, you often have to target and inhibit complement.
This idea of an underlying pro-clotting state, just waiting for a trigger, leads us straight to the two-hit hypothesis. That seems like a really fundamental concept for understanding why clots happen when they happen.
It is. The theory is pretty simple but really powerful for explaining the clinical pattern we see. So having the antiphospholipid antibodies circulating is hit one.
That sets the stage.
Exactly. It creates this underlying hypercoagulable state, this predisposition to clotting. But often the actual clot doesn't form until the patient experiences a hit two.
A second trigger.
Right. A second trigger is something that adds extra stress to the system, particularly to the endothelial cells, and kind of primes the coagulation pathway to activate.
Can you give us some common clinical examples of a hit two? Because this is often what actually brings the patient into the hospital, isn't it?
Absolutely. Probably the most common triggers we see are acute infections. Things like pneumonia, kidney infections like pyelonephritis, even just a bad case of the flu.
Okay.
Also, major surgery or significant trauma.
Yeah.
Being immobilized for a long period, even just high levels of systemic stress or inflammation from other causes. It's the combination, the underlying antibodies, hit one, plus this acute stressor, hit two, that allows the pathogenic process to finally overwhelm the body's natural defenses and form a clot.
Okay, so we've talked a lot about the formal criteria, but in the real world, hospitalized patients with APS often don't present like perfect textbook cases ticking all the Sydney boxes. We really need to talk about the broader spectrum of the disease. these extra criteria features, things that don't count for the formal diagnosis but are crucial clues.
Yes, this is so important for clinical practice. We absolutely must look beyond the strict criteria. Many patients, especially when they first present acutely in the hospital, might only have these extra criteria manifestations. If you're only thinking about a classic DVT or stroke, according to Sydney, you might miss the diagnosis initially.
Right, so starting with the classic vascular events, we know DVT and PE are the most common venous ones, and stroke and MI are the common arterial ones. But what about those less common, unusual sites of clotting that should really make you think, could this be APS?
Yeah, the unusual locations are major red flags. For instance, thrombosis in the upper extremity veins, especially if someone has a central line that's more common in APS. Or, maybe even more diagnostically challenging, is thrombosis within the splanchnic circulation, the veins inside the abdomen.
Like portal vein thrombosis.
Exactly. A patient presenting with unexplained portal vein thrombosis or hepatic vein thrombosis causing Budd-Chiari syndrome that demands an immediate APS workup. It's a classic, albeit less common, presentation. Other unusual sites could be renal veins, adrenal veins. Clots in weird places should trigger suspicion.
Okay, moving beyond the big clots, what about hematologic signs, things we see on the blood count? Or skin findings?
Thrombocytopenia, a low platelet count, is actually pretty common. We often see platelet counts that are mildly to moderately down, typically somewhere in the range of 40 to 100 times 109 per liter.
Is that low enough to cause bleeding?
Usually not. It's generally not severe enough to cause spontaneous bleeding, but it definitely complicates things, right? Because the main treatment for APS is anticoagulation, and doing that when the platelets are already low requires careful consideration and monitoring.
Right, and skin findings.
The classic skin finding is something called livedo reticularis. It's this faint, kind of lace-like or net-like purplish discoloration of the skin, often on the legs or arms. There's a more severe form called livedo racemosa, which looks more like broken, jagged, fixed patches of discoloration.
And what does that skin pattern mean?
It directly reflects sluggish blood flow or outright blockage in the tiny blood vessels right under the skin surface. It's a visible sign of underlying microvascular problems, often linked to APS.
Okay. And organ involvement can go further, right? Like hitting the heart or kidneys, sometimes mimicking other diseases entirely.
Yeah.
What might we see on an echocardiogram, for instance?
Yeah, cardiac involvement is important. The most characteristic finding is non-bacterial thrombotic endocarditis, which historically was called Liebman-Sachs endocarditis, especially when seen with lupus.
What does that look like on the echo?
You look for small vegetations, basically little clumps of thrombus and inflammatory material on the heart valves, or sometimes just generalized thickening of the valve leaflets. The mitral and aortic valves are most commonly affected.
And those vegetations are dangerous?
Very. They're essentially small clots stuck to the valve. If they break off, they can travel through the bloodstream and cause embolic events elsewhere, most commonly leading to strokes. So finding those valve changes is a big deal.
And the kidneys, how does APS affect them?
APS can cause a specific type of kidney damage called APS nephropathy. It typically manifests as thrombotic microangiopathy within the small vessels of the kidney. This often leads to high blood pressure, protein in the urine, and eventually can progress to chronic kidney disease or even renal failure if not recognized and managed.
Wow. And finally, what about the brain? Beyond the obvious large vessel strokes, are there other neurologic issues?
Absolutely. We have to be alert for these non-criteria neurological symptoms too. Things like recurrent seizures that aren't easily explained otherwise, chronic severe migraine headaches that don't respond well to typical treatments. And sometimes significant, otherwise unexplained cognitive dysfunction patients might describe it as brain fog.
And the thinking is these are caused by tiny clots.
That's the leading theory. These symptoms are thought to result from chronic, widespread tiny clots, or microthrombosis, affecting the small vessels in the brain, rather than one single large stroke event. Recognizing this whole spectrum from the classic clots to the livedo to the brain fog is vital, because sometimes managing these non-criteria features requires more than just anticoagulation. It might involve adding immunosuppressive therapy as well.
Okay, so if the underlying disease itself is complex, then this acute emergency catastrophic APS or CAPS, well, that sounds like a whole different level of crisis. This is the one that demands immediate recognition, especially in the ICU setting.
Yeah, CAPS is, thankfully, it's rare. We think it occurs in less than 1% of all APS patients. But its mortality rate is so high that it absolutely dictates its status as a top-tier medical emergency.
How is it defined? What makes it catastrophic?
It's defined by incredibly rapid, widespread clotting, specifically in the small blood vessels, the microvasculature. And this happens so fast and affects so many organs simultaneously that it leads to acute multi-organ failure. It's like the immune system just slammed the accelerator on microclotting everywhere all at once.
So what are the key diagnostic markers we're looking for in that incredibly acute scenario when time is critical?
The diagnosis requires evidence of involvement of at least 3 different organs, systems, or tissues, and this damage has to develop extremely quickly. The time frame is typically defined as less than 1 week.
3 organs in under a week.
Yeah.
Which organs are most commonly hit?
The kidneys are very frequently involved, leading to acute renal failure requiring dialysis. The lungs are another common target, causing acute respiratory distress syndrome, ARDS, or sometimes severe pulmonary hemorrhage. The central nervous system is often affected, presenting as confusion, seizures, encephalopathy, or widespread small strokes. The heart and skin can also be involved.
And given it's a small vessel, microvascular process, I imagine confirming it often relies on looking at tissue samples.
Ideally, yes. Although you absolutely cannot wait for pathology results to start treatment, a definitive CAPS diagnosis often involves getting histopathology from at least one of the affected organs. And what you're looking for is evidence of widespread microvascular occlusion, tiny clots blocking the small vessels. Again, critically, this should be without signs of primary inflammation in the vessel walls, distinguishing it from vasculitis.
It's that simultaneous rapid failure of multiple systems due to these microclots that really defines the catastrophe. We talked about the 2-hit hypothesis for regular APS thrombosis. What are the common triggers that seem to push a patient over the edge into this catastrophic state?
Yeah, CPS almost always has a clear trigger, a major systemic stressor.
No?
Overwhelming infection is probably the leading cause. Sepsis is a huge trigger.
Okay.
Major surgery or significant trauma is another well-known potent trigger. But perhaps the single most important preventable trigger, especially one we might see happen within the hospital setting, is the sudden, inappropriate withdrawal of necessary long-term anticoagulation.
Stopping warfarin, for example.
Exactly. If a known high-risk APS patient abruptly stops their warfarin, even for just a short period, the rebound hypercoagulability that follows can be absolutely disastrous and tip them straight into CEPS. It's a critical point for medication adherence and careful bridging if anticoagulation must be held.
That's a scary thought.
Yeah.
Now, despite this incredibly high risk, you mentioned the mortality rate is actually improving. It used to be over 50%, but now it's closer to 25–30%. What's made that difference?
The difference is early recognition and immediate aggressive treatment with what we call triple therapy. The absolute second that CAPS is clinically suspected, even before all the lab results are back, before you have tissue confirmation, this multi-pronged regimen must be started. You do not wait.
Okay, walk us through that emergency triple therapy. What are the 3 core components that work together?
Okay, component number 1, immediate high-intensity anticoagulation. This usually means starting unfractionated heparin as a continuous intravenous infusion.
Why heparin specifically?
We choose heparin primarily because it works very quickly, and critically, it has a very short half-life. That means if the patient starts having major bleeding complications, which is a constant worry when someone's in multi-organ failure, we can stop the heparin infusion and its anticoagulant effect wears off relatively quickly. That flexibility is vital.
Makes sense. Okay, component 2.
Component 2 is aggressive immunosuppression. This means high-dose corticosteroids or glucocorticoids. Usually, we give pulse doses of methylprednisolone intravenously. The goal here is to rapidly shut down the generalized autoimmune attack and the massive inflammatory response that's fueling the whole process.
Okay, anticoagulation and steroids. What's the third leg of the stool?
The third part is targeted immunomodulation, aimed at dealing with the circulating antibodies themselves or their effects. There are typically 2 main options here, either plasma exchange, PLEX, also known as plasmapheresis,
Right.
or intravenous immunoglobulin, IV.
How do they work differently?
PLEX is very effective because it physically removes the bad stuff from the patient's blood. The circulating pathogenic antiphospholipid antibodies, the activated complement proteins, other inflammatory mediators. It's like an oil change for the plasma.
Okay, and IV?
IV works differently. It's a concentrated infusion of antibodies from healthy donors. It's thought to work by modulating the patient's own immune system, perhaps by blocking antibody receptor sites, providing anti-idiotype antibodies, and generally reducing the harmful effects of the patient's own APL.
So how do you choose between PLEX and IV?
The decision often depends on local resources and expertise. PLEX requires specialized equipment and staffing. It also depends a bit on the specific patient's risk profile, like bleeding risk. But both PLEX and IVV serve that critical function of trying to dampen the specific autoimmune attack driving the CTPS.
Got it. Anticoagulation, steroids, and then either PLEX or IV. That's the core triple therapy. But what about those really severe cases, the ones that just don't seem to respond even to this aggressive first-line approach?
Yeah, unfortunately, some patients continue to deteriorate despite triple therapy. For these refractory cases, we have to consider newer, more highly targeted therapies. We mentioned earlier how critical complement activation is in amplifying the damage.
Right, the amplifier.
So drugs like eculizumab, which is a specific inhibitor of component C5, can be used as a rescue therapy. The idea is to directly block that key inflammatory pathway that's driving the microvascular thrombosis.
Okay, so targeting complement. Any other options?
Another approach sometimes used in these really severe unresponsive situations is rituximab. Rituximab targets CD20 on B cells, which are the immune cells responsible for producing antibodies.
So it tries to shut down the antibody factory.
Essentially, yes. By depleting the B cells, you hope to reduce the production of the pathogenic antiphospholipid antibodies over the longer term. It's more of an upstream approach compared to PLEX or eculizumab, but it's considered in those desperate refractory CTPS scenarios.
Okay, let's pivot a bit now. Let's talk about this sort of day-to-day practical management of an acute clot, maybe not full-blown CUFS, but a new DVT or stroke in a hospitalized patient, or suspect has APS. And then we absolutely have to get into the complexities of long-term anticoagulation. Right, so for that initial acute thrombotic event, you mentioned favoring rapid-acting agents. Is there a strong preference between using unfractionated heparin, UFH infusion, versus, say, injections of low molecular weight heparin, LMWH?
So the initial recommendation for treating an acute clot in APS generally follows standard VTE protocols. Either UFH or LMWH is acceptable and effective. However, in the hospital setting, particularly if the patient is critically ill, hemodynamically unstable, or has significant kidney dysfunction,
then you lean towards UFH.
we often lean towards the UFH infusion, yes. The main reason, as we discussed with CTPS, is its short half-life. It allows for much tighter control and titration, and crucially, you can turn it off quickly if the patient suddenly needs an emergency procedure or develops bleeding. That rapid reversibility is often preferred for unstable inpatients. LMWH is great, but it sticks around longer once injected.
Okay, that makes sense for the acute phase. But once the patient is stable, we need to think about long-term prevention, preventing the next clot. And this is where APS management really seems to diverge from the standard playbook for, say, a typical DVT, especially regarding the choice of anticoagulant and the target intensity.
Absolutely. This is critical. The standard approach for secondary prevention, especially after an unprovoked clot in an APS patient, is generally indefinite anticoagulation, lifelong treatment.
Lifelong. And the drug of choice has traditionally been
Vitamin K antagonists, or VKAs, the most common one being warfarin. And the consensus guideline recommendation is to target a standard intensity INR aiming for a range of 2.0 to 3.0.
not higher. I feel like I remember hearing about higher INR targets for APS in the past.
You're right. There was a period where some experts advocated for a higher target INR, maybe 3.0 to 4.0, particularly for patients with recurrent clots despite being in the 2-3 range, or those with arterial events. The thinking was more must be better.
But the data didn't support that.
Correct. Randomized controlled trials that specifically compared the standard INR range, 2 to 3, versus a high-intensity range, 3 to 4, generally found that the higher target didn't offer any significant additional protection against recurrent clots, but it did substantially increase the risk of major bleeding complications. So, the current recommendation is stick to the standard INR of 2 to 3, but focus on maintaining consistency within that range. Time in therapeutic range is key.
Okay, INR 2 to 3 with warfarin is the standard for long term. Now here's the really crucial warning, the part we absolutely need to emphasize for everyone listening. What about the direct oral anticoagulants, the DOACs? Like apixaban, rivaroxaban, they're used everywhere else now for VTE. Are they okay in APS?
This is probably the single most important practical management point for non-specialists dealing with APS patients right now. The current guidance, based on accumulating evidence, is quite clear and emphatic. DOACs are generally not recommended for patients with high-risk APS.
And high risk specifically means?
Specifically, it refers to those triple-positive patients we talked about earlier, the ones positive for lupus anticoagulant, anticardiolupin antibodies, and anti-2-GPI antibodies.
So for triple-positive APS, DOACs are generally out.
They are generally contraindicated based on current evidence. Multiple studies, including the important RAPS trial and others, have compared DOAs directly against warfarin in APS patients. And what they found, particularly in that high-risk triple-positive subgroup, was that DOAs were associated with inferior efficacy compared to warfarin.
Inferior in what way? More clots.
Yes. Significantly higher rates of recurrent thrombotic events, particularly arterial events like stroke and myocardial infarction, were seen in the triple-positive patients who were randomized to receive a DOAC compared to those on warfarin.
Wow. But why? Why would drugs that work so well for preventing standard blood clots seem to fail, or even be worse, in high-risk APS?
It likely comes back to that concept of APS being a thromboinflammatory disorder, not just a simple clotting problem.
Ah, the inflammation again.
Right. DOACs, like rivaroxaban or apixaban, are very targeted. They directly inhibit one specific clotting factor, either factor XA or factor thea thrombin. They work purely by interrupting the coagulation cascade itself.
Oh.
Warfarin, on the other hand, works differently by inhibiting the production of multiple vitamin K-dependent clotting factors. But beyond its effects on coagulation, there's growing thought that warfarin might have other non-coagulation-related effects, perhaps some anti-inflammatory properties or effects on endothelial cell activation or platelet function that DOACs simply don't possess.
So warfarin might be doing more than just thinning the blood in APS.
That's the hypothesis. It might be better at dampening down that underlying autoimmune and inflammatory trigger, particularly in the highest-risk patients where that trigger is strongest. Whatever the exact mechanism, the clinical trial data currently tells us that for triple-positive APS patients needing long-term anticoagulation, warfarin, with a target INR of 2.3, remains the gold standard and preferred agent over DOACs.
What about lower-risk APS, like someone only positive for one antibody, say ACL?
That's a bit more debated, and practice varies. For lower-risk, single-positive patients, particularly those with only a venous event history, some experts might consider a DOAC. But even then, it's often done with caution and close monitoring. The safest default, especially if there's any uncertainty, is still warfarin for most APS patients requiring indefinite anticoagulation.
That is a critical distinction. Okay, shifting gears slightly to the diagnostic workup itself when a patient is admitted. We need to talk about the challenges in actually getting the test done correctly, especially the lupus anticoagulant. What are the key initial labs we look for?
So when you suspect APS in a hospitalized patient, the initial lab should always include a complete blood count, specifically looking for that characteristic mild to moderate thrombocytopenia we discussed.
Platelet count.
Right. And then you absolutely need baseline coagulation studies, specifically the prothrombin time, PT, and the activated partial thromboplastin time, APTT.
And the APTT might be the first clue.
It often is. An unexplained prolongation of the APTT that doesn't correct when mixed with normal plasma. That can be the very first laboratory hint suggesting the presence of a lupus anticoagulant. Remember, the LA inhibits clotting factors in the test tube, hence the prolonged clotting time.
But we know that testing for the lupus anticoagulant itself is notoriously tricky, especially when the patient is acutely ill or already on blood thinners.
It is incredibly tricky. This is a major pitfall. The functional assays used to detect LA activity, like the DRBVT or silica-based APTT tests, are highly susceptible to interference from therapeutic anticoagulants.
Which ones interfere?
Pretty much all of them. Unfractionated heparin, low molecular weight heparin, and definitely the DOACs can all interfere with LA testing, potentially causing false positive results, false negative results, or just making the test completely uninterpretable.
So that creates a real clinical dilemma, doesn't it?
Yeah.
You need to treat the clot immediately with anticoagulants, but the treatment itself messes up your ability to diagnose the underlying cause.
Exactly. It's a common problem. If a patient is on heparin or LMWH, for example, we often can't rely on the APTT to monitor the drug's effect because the LA itself might be prolonging the APTT. In those cases, we have to use anti-factor XA levels to monitor the heparin effect instead.
And for actually confirming the LA diagnosis.
If you strongly suspect APS based on the clinical picture, but the initial LA testing is confounded by anticoagulation, you often have to plan carefully. Sometimes you might need to wait for a period when the anticoagulant can be safely held, like before starting warfarin, or switch to an anticoagulant less likely to interfere, or specifically request specialized LA assays from the coagulation lab that are designed to minimize interference if available. And remember, you still need that confirmatory test 12 weeks later, ideally when anticoagulation interference is minimized, to prove persistence. It requires planning.
Definitely adds layers of complexity. Okay, finally, to wrap up this section on diagnosis and management in the hospital, avoiding misdiagnosis is crucial. Getting it wrong can lead to the wrong treatment, which could be disastrous. We need to be able to rapidly differentiate APS from other conditions that can cause a similar picture of thrombosis and maybe low platelets. The differential diagnosis is vital, especially in the ICU.
Absolutely critical. Let's focus on maybe the top 3 mimics that cause the most confusion in practice. First one, heparin-induced thrombocytopenia, or HIT.
Right, both cause clots and low platelets, often in hospitalized patients. How do we tell HIT apart from APS?
Several key features distinguish HIT. First is the timing. HIT typically occurs 5 to 10 days after starting heparin or being exposed to it. The platelet drop in HIT is usually quite significant, often more than a 50% fall from baseline. And crucially, HIT is mediated by specific antibodies against the platelet factor for heparin complex, anti-PF4 heparin antibodies, which we can test for. While both cause clots, HIT is predominantly a venous thromboembolic disease, although arterial clots can occur. And the management is diametrically opposed. In APS, you generally start or continue anticoagulants. In HIT, you must stop all forms of heparin immediately and switch to a non-heparin anticoagulant. Getting this wrong is dangerous.
Okay, HIT is about timing and the specific antibody. What's the second big mimic?
Second is disseminated intravascular coagulation, DIC. This is often seen in the context of massive systemic insults like severe sepsis, major trauma, or certain obstetric emergencies.
And DIC is different because it's more of a consumptive process, right? Using up clotting factors.
Precisely. DIC is characterized by widespread activation of coagulation and fibrinolysis simultaneously. The body is essentially clotting and bleeding at the same time. This leads to a consumptive coagulopathy.
How does that look on labs compared to APS?
In DIC, you typically see prolonged PT and APTT, yes, but also significantly low fibrinogen levels and elevated D-dimer, reflecting that consumption of clotting factors and breakdown of clots. Platelets are usually low, often severely. Patients with DIC have a very high risk of bleeding. In contrast, APS typically presents with mild to moderate thrombocytopenia, but coagulation factors like fibrinogen are often normal or even elevated as part of the acute phase response. The primary problem in APS is thrombosis, not usually spontaneous bleeding unless they're over-anticoagulated.
Okay, DIC is consumption and bleeding risk. What's the third key condition to differentiate, especially when microvascular clots are suspected?
The third major one to consider, particularly if you see evidence of microvascular thrombosis along with low platelets, is thrombotic thrombocytopenic purpura, or TTP.
TTP. How is that different from APS, especially from something like CAPS, which also involves microclots?
TTP is a rare but very severe acute condition characterized by microangiopathic hemolytic anemia, MAHA. There are 3 core features you look for. First, severe thrombocytopenia, often with platelet counts less than 20,000. Second, evidence of MAHA on the blood smear, you see schistocytes, which are fragmented red blood cells shearing as they pass through blocked small vessels. Third, signs of end organ damage due to microthrombi, often neurological changes or kidney injury.
Schistocytes are key for TTP.
Schistocytes are a hallmark finding on the peripheral blood smear in TTP. Crucially, TTP is caused by a severe deficiency in the activity of an enzyme called ADAMTS13, which normally processes von Willebrand factor. Testing ADAMTS13 activity is key to confirming TTP. While severe APS, particularly CCAS, can cause microvascular thrombosis and organ damage, it typically lacks the profound hemolytic anemia with prominent schistocytes and the severely deficient ADAMTS13 activity characteristic of TTP.
And the treatments are totally different.
Completely different, and getting it right immediately is life-saving. The primary urgent treatment for TTP is plasma exchange, PLEX, to replace the deficient ADAMTS13 and remove harmful antibodies. The primary treatment for APS-KPS is anticoagulation and immunosuppression. Confusing these two can have fatal consequences. So recognizing those key distinguishing features, severe MHA with schistocytes and low ADAMTS13 for TTP, is paramount. #tag outro, prognosis, and future focus. So just to wrap things up, let's quickly summarize the prognosis depending on how severe the presentation is. For an APS patient who gets hospitalized with an acute thrombotic event, but not CFPS, there's still a significant mortality risk, especially if they end up needing ICU care. Some studies report in-hospital mortality rates as high as 26% in that setting.
Wow, that's still quite high.
It is. However, the data also clearly shows that prompt diagnosis and initiation of adequate anticoagulation, followed by appropriate long-term VKA therapy targeting that INR of 2-3, is strongly linked to better long-term survival. Early and effective treatment matters hugely.
Okay. And for catastrophic APS, for CIPS?
For CAPS, the mortality unfortunately remains the most significant challenge. As we said, it's still hovering around 25 to 30% even with modern therapy. But, and this is the crucial point, that 25-30% represents a huge improvement compared to the historical rates of over 50% mortality seen before the widespread adoption of aggressive triple therapy.
So that immediate combination of anticoagulation, corticosteroids, and immunomodulation, PLEX or IVX, has made a massive difference.
A massive life-saving difference. It underscores the need for rapid recognition and intervention in CPS.
This really brings us back full circle to the idea that APS isn't just a clotting disorder, it's fundamentally this thromboinflammatory process. And it seems like management is slowly evolving to address both parts of that equation, looking beyond just anticoagulation, especially for chronic care.
Exactly. We're seeing more interest in therapies that target the underlying inflammation or the antibody production itself, particularly for complex or refractory cases. For instance, we know that hydroxychloroquine, which is commonly used in SLE, Plecanil, there's evidence suggesting it might actually enhance the effectiveness of standard anticoagulation therapy, particularly in patients who have both APS and lupus. It seems to have some beneficial effects beyond just treating the lupus itself.
Interesting. And those more targeted immune therapies we mentioned for rescuing CTPA patients, are they being explored for chronic use too?
They are, increasingly so. Therapies like rituximab, the B-cell depleting agent, are sometimes used off-label for managing difficult non-criteria manifestations of APS, like severe refractory thrombocytopenia or skin ulcers. And there's growing interest in the potential role of complement inhibitors, like eculizumab, not just for acute CTPA rescue, but potentially for select patients with very severe refractory chronic APS who keep clotting despite optimal anticoagulation.
So the goal is really shifting, isn't it? From just preventing the downstream clot to maybe trying to neutralize the upstream pathogenic process itself.
That's exactly the direction things are heading. It's recognizing that we need strategies to stop the initial antibody binding, the cell activation, and the inflammatory damage that ultimately allows the clot to form in the first place, rather than just dealing with the clot after it happens.
Which leads to maybe a final thought for our listeners. Given that incredibly high risk of recurrence, especially for those triple positive patients who, let's face it, sometimes still have breakthrough clots even when they're seemingly perfectly managed on warfarin, we have to ask, how might future research into these targeted, perhaps anti-inflammatory or immunomodulatory therapies eventually move us beyond just relying on standard lifelong anticoagulation? Could we truly neutralize the effects of these powerful pathogenic autoantibodies?
That's the ultimate goal, isn't it?
Yeah. I mean, if we know complement is a key amplifier and B cells are the antibody source, should we perhaps be prioritizing research into using complement inhibitors or targeted B-cell therapies much earlier, maybe even as part of chronic management for the highest risk patients, rather than just reserving them as a last resort for CIPS? The underlying biology seemed to suggest that the future of APS management might lie much more in targeted immunology. Something to think about.